Hello and welcome to the latest CSF podcast on axial spondyloarthritis. We'll be bringing you new episodes on a bi-monthly basis alongside our psoriatic arthritis podcast. And we'll also be supplying you with monthly slide decks to help keep you up to date with the latest research and publications in the field of axial SpA. First of all, allow me to introduce myself. I'm Hideto Kameda, Professor of Internal Medicine at Toho University, Tokyo. Joining me today is Dr. Sofia Ramiro, a consultant rheumatologist and senior researcher at Zuiderland Medical Center and Leiden University Medical Center in the Netherlands. And of course, if you want to find out more about us and the papers we discussed today, please head over to the CSF website, www.cytokinesignaling.com.
Thank you very much, Hideto. Today we will be discussing actually two papers. The first paper aimed to use mediation modeling to determine whether tofacitinib improved fatigue symptoms directly or indirectly. And our second paper shows that intravenous golimumab reduces fatigue symptoms in patients with ankylosing spondylitis. So I think we can get started with our first paper, which is entitled Pain and Inflammation as Mediators of Tofacitinib Treatment Effect on Fatigue in Patients with Ankylosing Spondylitis, a Mediation Analysis. So as we know, as key symptoms of axial spondyloarthritis or ankylosing spondylitis, we have back pain, fatigue, joint stiffness, and reduced spinal mobility. And the treatment of these symptoms is actually a priority for patients with ankylosing spondylitis and their healthcare providers. Mechanisms underlying the interrelationships between these symptoms, inflammatory markers, and treatment may sometimes remain unclear. Studies have shown that tofacitinib improves fatigue, improves back pain, improves morning stiffness, and CRP. And actually, we know that randomized controlled trials usually include confounding variables, but not really mediators, so not really variables that are in the causal pathway. And therefore, no study has been carried out to assess causality between these variables. So the aim of this study was to use mediation analysis to describe the interrelationships between fatigue, pain, morning stiffness, CRP in tofacitinib treatment in patients with axial spondyloarthritis. So this study was a post-hoc analysis of two interventional randomized placebo-controlled parallel clinical trials. One was a phase 2, where patients with radiographic axial SpA or ankylosing spondylitis were administered tofacitinib BID for 16 weeks. And the other trial was a phase 3 trial, also with patients with radiographic axial SpA, which received tofacitinib 5 mg BID or placebo for 48 weeks. And there were two mediation models that were used. One that used the Tofacitinib as the instrument measuring fatigue, and the other that used BASDAI question 1 as the instrument measuring fatigue. And so what was concluded from this, or what was the results showed, is that mediation models show that tofacitinib indirectly reduces fatigue, and there was no statistical significance for direct effects. So the Tofacitinib-based model showed that 131% of the treatment effect was indirect, whereas the BASDAI question 1 based model showed that 123% of the treatment effect was indirect, so without direct effect of tofacitinib on reduction of fatigue. So both models showed that tofacitinib had an indirect effect via a direct effect on pain or morning stiffness or both. So if we look first at the model that used Tofacitinib for the measurement of fatigue, we see that 57% of the effect of tofacitinib on fatigue was mediated via morning stiffness and back pain. 49% or 50% was mediated via morning stiffness alone, 19% via back pain alone, and a very small effect, 2.5% non-significant effect via CRP and back pain, and 3.1% non-significant via CRP alone. So in short, effect from tofacitinib on fatigue is mediated either via back pain or stiffness or both. And actually, but the BASDAI Q1 based model showed exactly the same effect of tofacitinib on fatigue mediated via morning stiffness and back pain, or any of those alone, again with a minor effect and non-significant via CRP. And then a second model excluded the CRP variable from the model, as there was initially no significant effect on CRP, on mediation through CRP, and facet-based model showed that tofacitinib had a 44% effect on fatigue via morning stiffness and back pain. So similar results as the mediation through CRP was not relevant or not significant. In conclusion, this study showed that tofacitinib improved fatigue symptoms in patients with radiographic AxSpA indirectly via effects on morning stiffness and pain. And actually, the authors conclude that more research is required to investigate how the pain relief or the relief of pain and stiffness contribute to the observed improvements in fatigue. So actually, I think this is a very interesting study and innovative. I think there's a lot going on in terms of the possible direct effects of JAK inhibitors, so in this case, tofacitinib, on fatigue. And actually, I think it's good to investigate that, good to test that. It's clearly an unmet need in our daily clinical practice and of our patients who really are desperate for an effective treatment on fatigue. And I think this study is confirming what I actually keep telling my patients, not that it's perhaps good news, but the fact that we can mostly intervene on fatigue when the disease is active, and therefore here we have confirmation that we can intervene on pain and on stiffness and therefore improve fatigue, but using treatment solely to treat fatigue does not seem to be efficacious, and here we don't see a direct effect from tofacitinib on fatigue years either. So I think it's useful to have this additional information and additional analysis, because of course tofacitinib has an effect on fatigue, but in patients with active disease, and now through this analysis we learned that effect is mediated by an improvement in back pain and in stiffness. So I was quite happy to see these results convincing. I think they are very convincing. What do you think, Hideto?
Thank you for your fine presentation. Very complicated data. And I thought that sleep disturbance is likely to be an important factor of fatigue symptoms, and the association of sleep disturbance with nocturnal pain and morning stiffness may be considered. And also, a small difference between the results from FACIT-F-based model and those from BASDAI question 1 based model was observed. And FACIT-F-based model seems to be better than BASDAI question 1 based model. Do you think so?
I think those are two very relevant comments. So one is on the sleep problems in addition to fatigue. I agree, those are recognizable problems and priorities of our patients for improvement. I don't know whether the results would be different if sleep problems were considered in the model. They were not considered. I don't know whether they have been collected. I wouldn't be surprised if the results were similar, though, in the sense that we can also impact or have an impact on sleep problems by intervening on the activity of the disease, but probably not directly on the sleep problems with our drugs. But of course, this is pure speculation because we haven't seen the data. And you had a second question on the performance of the models. Yes, I think the FACIT is a more solid instrument when it considers the measurement of fatigue. BASDAI question 1 is simply only one question, therefore much more feasible, and therefore it's included, for example, in the core set of instruments to be collected in all trials with the AxSpA. So I think it's actually good that authors used both measures. In general, I think the results are consistent for both of them. Probably the FACIT model performs a little bit better as it measures more thoroughly fatigue, let's say like that. But in terms of overall conclusion, I think it's the same, that the impact of the effect of JAK inhibitor, of tofacitinib in this case, on fatigue is mediated through the effect on pain and on stiffness.
Okay, thank you, Sophia. So over to our second paper titled Effect of Intravenous Golimumab on Fatigue and the Relationship with Clinical Response in Adults with Active Ankylosing Spondylitis or Radiographic AxSpA in the Phase 3 Go-Alive study. A study background. The Go-Alive study showed that IV-golimumab reduces the signs and symptoms of active AxSpA in adults of 18 years old of age or greater. And fatigue, a common AxSpA symptom, was not specifically assessed during the trial. The aim of the study was to observe the effect of IV-golimumab on fatigue in AxSpA patients and to determine the association of fatigue improvement with clinical response post-hoc in adults with active AxSpA in the Go-Alive trial. Now, I briefly introduce the methods. The study was a post-hoc analysis of Go-Alive, a Phase 3 double-blind randomized placebo-controlled study. 208 patients were randomized 1-to-1 to one of the following: golimumab 2 mg per kilogram for 103 patients, or placebo, then golimumab 2 mg per kilogram since week 16 for 105 patients. Patients were monitored for 52 weeks. Treatment group, IV-golimumab was administered at week 0, 4, 12, then every 8 weeks up to week 52. In the placebo group, placebo at weeks 0, 4, and 12, and then IV-golimumab at weeks 16, 20, then every 8 weeks up to week 52. The primary endpoint was the ASAS-20 response. Secondary endpoints included other ASAS responses, ASTAS response, and BASFI response. And as a result, baseline patient demographics and disease characteristics were comparable between treatment groups. The proportion of patients achieving the ASAS-20 response at week 16 was significantly higher for AxSpA patients. 86.1% for those with BASTI fatigue improvement score by 0.73 or greater, versus only 34.6% for those with a lower score, and 86.4% for those with SF36 vitality improvement by 3.98 or greater, versus only 40% for those with a lower score. Similar differences were also seen for ASAS-40, ASAS-5 of 6, ASAS partial remission, ASAS clinically important improvement, ASAS major improvement, and ASAS inactive disease scores. All ASAS and ASAS responses were sustained at week 52. Patients in the placebo group had significantly lower rate of achieving BASTI fatigue improvement score 0.73 or greater, and SF36 vitality improvement of 3.98 or greater up to week 16. After starting golimumab treatment, there was no significant difference between the initial placebo followed by golimumab group and the golimumab throughout group up to week 52. In conclusion, golimumab improved fatigue symptoms in AxSpA patients at week 60 at week 52. BASTI fatigue and SF36 vitality scores for patients treated with IV golimumab significantly improved at week 2 and week 8, respectively. placebo group fatigue scores were statistically similar to the treatment group after crossover to IV-golimumab at week 16, which was sustained up to week 52. Dr. Sofia, how about your comments on that topic?
Thank you, Hideto, for the very nice presentation. And I think it's very good that we have today this podcast with exactly these two papers that I think are somewhat interconnected, especially they are both dealing with fatigue, which, as we mentioned before, is a prominent symptom and struggle of our patients. I think it's important to know that as fatigue has not been measured in the trial of golimumab, that now proxy for it has been tested, and we have seen that golimumab has an impact on fatigue as well. So I think it's important to have that information. I think it's now an invitation to make a link with the first paper we were discussing. And now the question is, although it was not analyzed in this paper, I know, but the question is, do we think, or can we speculate about whether there will be a direct effect of golimumab on fatigue, or whether we expect this effect to also be indirect through the suppression of or control of pain and the control of stiffness? Do you have any thoughts on that in the Hideto?
Yeah, it's very, very difficult because direct or indirect depends on the data obtained from the clinical trials. So the clear-cut difference between direct effect or indirect effect is very difficult, I think. But we are very happy with these results, and fatigue is very important for patients. So the measurement of fatigue is very difficult for us because it's only subjective. But some clue to measure fatigue through other symptoms or other measurement is very important. And currently in rheumatoid arthritis or systemic lupus erythematosus, also fatigue is very important measurement. So it is also true for AxSpA. Okay,
sure, I agree with you. I think it's important to consider fatigue in our patients, and in that sense, the question one of Bosdijk is something very easy to apply in daily clinical practice. And I think, of course, I do not have the data, and I'm only speculating. But if I see that even JAK inhibitors that are known for eventually having a direct effect on fatigue, and then when mediation analysis is conducted, we only see an indirect effect, I would think or speculate that golimumab also has an indirect effect on fatigue through the control of inflammation, either control of pain or control of stiffness. But of course, it would be interesting to see those data as well.
Yes, and also so comparison between TNF inhibitors and JAK inhibitors for fatigue improvement may be very important. Yeah. Thank you, Sofia.
You're welcome.
Thank you for joining us for this AxSpA podcast brought to you by the CSF. We really hope you find it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to cytokinesignaling.com, where you'll find detailed summary slides of each of the papers. See you next time.